Today from the Department of Anesthesiology. This is Dr. Ben Klosel. Ben has been on the faculty here since 2016. He did his medical school in Tübingen, Germany, and followed that up with a residency and fellowship at Boston Children's Hospital. Ben's work has focused here mostly around the cardiac anesthesia group, but he also has interests in inborn errors of metabolism and anesthetic interactions, as well as the mucopolysaccharidoses and adrenoleukodystrophy. So Ben will be talking to us about sort of a back to basics on respiratory physiology and respiratory care. So Ben, thank you for coming.
Thank you very much. Sorry. Okay, please let me know if there are any issues of understanding or hearing me. I think that should be working. So good morning. Thank you very much for coming today, and thank you very much for the opportunity to talk to you in the setting of pediatric grand rounds. So as mentioned, the topic that I'm going to be discussing today is pediatric respiratory care. So first of all, I do not have any financial relationships or conflicts of interest to disclose. I will be briefly mentioning certain airway devices that we're using here. Some of them are trademarked or registered, but we're basically using it in a general use around the hospital. And I've prepared a small outline. So my goals for today are going to be to review basics about pediatric pulmonary and airway physiology, as well as define the concept of oxygenation and ventilation. And then the main focus is going to be non-invasive ventilation. We'll briefly touch on invasive ventilation and then discuss a little bit about blood gases. Along those, the goals are defined along the outlines. But what I really want to do today is, with the focus on non-invasive ventilation methods, I would like to bring up some of the evidence behind why we're using them and why they are so beneficial over time. So to start, the first thing I brought you was a little picture of our daily life, a picture of a scene in the operating room. And as a anesthesiologist, I take care of patients during surgical procedures. And in a majority of surgical procedures, our patients have invasive airways. So we use endotracheal tubes, we use tracheostomies, and that is basically how we manage a patient during the procedure. Now, because today our focus is non-invasive ventilation, I would like to take a minute to recognize a different group of people, our respiratory therapists. And it's important to kind of understand that the respiratory therapists are the point persons in general questions about respiratory care. They're the people that are all around the hospital. They provide care on the intensive care units, on regular wards. They're in the emergency department, in the pediatric sedation units, and they're a tremendous, great asset for us in the operating room. So thank you for all that great work. Now, at the same time, I want to put out a little disclaimer. So, talking to an audience at the Department of Pediatric Grand Rounds, I recognize that there are physicians and practitioners present here whose daily lives revolve about decisions regarding ventilatory support. So, specifically, people working in the NICU, in the CVICU, in the PICU, and of course, our pulmonologists. So, I'm going to be trying to still give a nice review and a refresher, but more importantly, I'm going to try to make it worth your while by, again, discussing the more recent evidence of why we do things and what we do. So, without further ado, to start with the talk, looking at pediatric pulmonary and airway physiology. So let's start on one end of the spectrum here. Let's take a look at the premature neonate. So a premature neonate typically requires a lot of respiratory support because, owing to the fact that the whole respiratory system, the anatomy and the physiology is underdeveloped and needs time to develop. But even a full-term baby still requires certain adjustments to their ventilatory pattern to actually be able to maintain respiratory homeostasis. So as the respiratory system over time matures, you probably reach your peak performance level around late adolescence or early adulthood. And then, unfortunately, as we all know, the performance of the respiratory system again begins to decline towards older age, and that's secondary to disease processes, but also simply secondary to aging. Now, looking at respiratory anatomy, let's divide the respiratory system into three basic components. So one are the conducting airways, one are the lungs, and one are the respiratory muscles. And look at what's the main difference between premature neonates, and the adult that makes it harder for our younger patient populations to maintain that respiratory homeostasis. So starting with conducting airways. The big picture here is that in young children, neonates, conducting airways are much smaller compared to the adult. And that has major implications. The radius and diameter of conducting airways is inversely proportional to resistance. So meaning that a decrease in diameter leads in a significant increase in resistance. So disease processes like bronchiolitis, for example, or a patient who was intubated for a long time and develops subglottic stenosis, small decreases in airway diameter lead to relatively high increase in resistance compared to the adult. The other part is that conducting airways and terminal airways are underdeveloped, and basically the forces that try to collapse the lungs and the conducting airways are stronger than the forces that try to keep them open. So in neonates, that leads to a very early airway closure during breathing. And lastly, neonates have a low functional residual capacity. And functional residual capacity is a very important concept that we're going to be discussing more in later slides, because that explains a lot of the problems that we're encountering with our young patients, but it also explains a part that we can correct with our non-invasive ventilatory ways and help. So the low FRC accounts for diffuse microatelectasis. FRC, functional residual capacity, is essentially residual volume and expiratory reserve volume that basically maintains the lungs after you take an exhalation, standard exhalation. So that's the resting state of the respiratory system. A little bit more about that later. Next, the lungs. So obviously, premature neonates have a surfactant deficiency that leads to alveolar atelectasis. And then overall, there's incomplete alveolarization, and newer evidence points to the fact that alveolarization is not completed until about 6 to 8 years of age. So what reduced availability of alveoli, there's a reduced gas diffusion surface, which also promotes problems with oxygenation. And then lastly, our respiratory muscles, specifically the diaphragm, intercostal muscles, accessory muscles, and abdominal muscles. The diaphragm, as the major respiratory muscle, has the big problem in neonates and infants that it has a low muscle mass, and the percentage of type 1 slow twitch muscle fibers is lower. And those are the muscle fibers that are harder to fatigue, and that puts neonates at a higher risk for respiratory muscle fatigue over time. And then obviously the overall respiratory system geometry, so very compliant chest and rib cage with a cylindrical thorax with horizontal rib position, makes breathing patterns more difficult. Okay, so we're at the point of functional residual capacity. So that's really an important concept. And as I mentioned, volume remaining in the lungs after normal passive expiration. So let's take a moment to take a look at this spirogram here. So what we have here is a regular inspiration expiration, right? So this is our tidal volume that we're looking at. Now we have capacity to take a really deep inspiration, our inspiratory reserve volume, and we have the capacity to take a really deep expiration, our expiratory reserve volume. So all of this is an area that we can utilize our vital capacity. There is an area down here called residual volume that's going to be remaining in the lungs even if we take a really deep breath out. And our functional residual capacity is made up by that residual volume as well as the expiratory reserve volume. Now in neonates, the functional residual capacity is from the get-go lower. Plus, in addition to it, it's not static, it's dynamic. And neonates have ways of maintaining the functional residual capacity by making some adjustments during their respirations. So think about the functional respiratory capacity as a gas volume that promotes oxygenation and ventilation, but also it promotes keeping airways open and keeping alveoli open. So neonates have a tonic inspiratory muscle activity. So meaning that even after a deep inspiration and you start your exhalation, their inspiratory muscles remain active, preventing a very deep expiration and alveolar collapse. The next part is laryngeal braking, also called grunting. So during expiration, neonates adduct their vocal cords, and what that causes is it generates some auto PEEP, positive end expiratory pressure, and that is also helpful in keeping alveoli open. Now the other part is their high respiratory rate, and the fact that inspiration starts in mid-expiration promotes the fact and prevents further alveolar collapse by deep expiration. And to make this a little bit more understandable, at the concept of what we call closing capacity. The functional residual capacity and the closing capacity, if we put those two concepts together, it will make it more understandable what happens. So again, functional residual capacity is the resting lung volume, and that's very important. This is affected by a couple of things. So body position. My functional residual capacity is relatively high when I'm standing and talking here to you. If I go in a sitting position, it's reduced slightly. If I go in a lying position, it's reduced even further. And now, if I provide anesthesia or sedation, that functional residual capacity takes another drop down. The only good way for us to increase functional residual capacity is by providing continuous positive airway pressure, or PEEP. So that's a way with our non-invasive ventilation to increase that number. Now, closing capacity is a lung volume at which small airways begin to collapse. This one is not minimally affected by position, sedation, and anesthesia, but it's affected by age. So the best closing capacity, the lowest one, is in an adult individual. A neonate has a higher closing capacity, and closing capacity again begins to increase with age. Especially at 70 to 75, it equals functional residual capacity. So now looking at this diagram, at this picture here. So this is your residual volume, and this is your functional residual volume here. The adult individual's closing capacity is below the functional residual capacity, meaning that if you take regular breaths, you inspire, expire, your airways tend to not collapse. Some of your airways might collapse if you take a deep expiration, but in an adult, you typically are able to re-recruit those collapsed alveoli units by taking another deep inspiration. Now take a look at a neonate. The closing capacity for a neonate is essentially around tidal volume breathing. So a normal neonate that breathes at a normal rate and normal tidal volumes has a small component of alveolar collapse at baseline. So that makes it much harder to maintain good oxygenation. Now, the concepts of oxygenation and ventilation are very important. And to kind of illustrate this, I tell you a little story about what once in a while happens all around the country in every major hospital. So let's say you have a patient that goes for a procedure, has a surgery, has anesthesia, gets an endotracheal tube placed, gets extubated at the end, and goes to the post-anesthesia recovery unit. So you walk through that unit and you see that patient sleeping, has an oxygen mask on, gets supplemental oxygen. The pulse ox reads 99%. Looks good. Okay, you continue your rounds. An hour later, you come back. Patient is still asleep. Oxygenation level perfect, 99%. You're happy. In another hour, you make another round, and that patient is still asleep. So moreover, you go, you poke them, and there's really no reaction at all. They're totally obtunded, deep asleep. So before you kind of embark on that big stroke workup, you get an arterial blood gas, and while you figure out that your oxygenation is actually quite okay, your partial pressure of your carbon dioxide is in the over 100. So it's a big difference if we talk about oxygenation, which is the movement of oxygen from the alveolus to blood, which determines the partial pressure of oxygen in the blood, and ventilation, which essentially talks about the exchange of air between lungs and the environment. And that determines your partial pressure of carbon dioxide. So some people refer to problems with oxygenation as the quick killer, and problems with ventilation as kind of the slow killer that takes a little bit of time to cause problems, but ultimately will cause problems. So oxygenation is depending on the inspired oxygen concentration. So we right now, breathing room air, we have an FiO2 of about 21%. It depends on ventilation perfusion matching. So every alveolus that receives oxygen needs pulmonary vasculature that supplies it. And gas exchange by diffusion via pulmonary surface that can also be impaired. And that leads us to the reasons for hypoxemia. So hypoventilation and respiratory muscle weakness, when you are unable to maintain an adequate respiratory rate or you are unable to maintain good tidal volumes, your carbon dioxide pressure increases in the alveolus, and according to the alveolar gas equation, it leaves less room for oxygen to move into the blood and oxygenate. But the more important part for our pediatric patients, what we are more dealing with on a regular basis, is actually VQ mismatch, so ventilation perfusion mismatch. VQ levels greater than 1 mean you have dead space ventilation, for example, in the setting of a pulmonary embolism. So your alveoli are ventilated, but there's no lung vasculature that perfuses them. So it's essentially unnecessary or missed ventilation. On the other hand, VQ levels of less than 1 are accounting for intrapulmonary shunting atelectasis, and that's what pretty much often happens. We talked about all the airway closure in younger kids. We talked about sedation or anesthesia that leads to atelectasis and alveolar collapse. And then obviously low inspired FiO2. If you climb a mountain with height, you reduce your inspired oxygen level. And the alveolar diffusion barrier, for example, in the setting of pulmonary edema or severe ARDS, where you basically have fluid or casts in the alveoli and you cannot oxygenate through those. Now, on the other side, we have ventilation, and ventilation is essentially dependent on how you breathe, right? So your tidal volumes, how deep of a breath you take, and your respiratory rate. And that all accounts for alveolar ventilation and modifies your partial pressure of carbon dioxide in the blood. So reasons for hypercapnia and increased level of carbon dioxide are hypoventilation, VQ mismatch, increased CO2 production, and overfeeding. Okay, so this chart helps us to kind of look at things we can do to improve oxygenation and ventilation, and specifically in patients with a natural airway versus in patients that are intubated. So oxygenation is easily addressed by providing additional oxygen. So either supplemental oxygen, with, for example, a face mask or a nasal cannula, or an increase in the inspired oxygen concentration in the intubated patient. At the same time, measures that increase your functional residual capacity will help with oxygenation. So provision of CPAP via the non-invasive ventilation route, or even better, BiPAP, where you supplement the inspiration, will help with oxygenation. At the same time, in the intubated patient, you can increase your mean airway pressure, mostly via the increase in PEEP, or you can use recruitment maneuvers, which actually aim at recruiting alveoli that are collapsed in the process. For ventilation, easy ways to help with that in the spontaneously breathing patients are to relieve airway obstruction and avoid respiratory depressants. CPAP helps to a certain extent if hypoventilation is related to obstruction. So again, your adult patient who has obstructive sleep apnea will benefit from CPAP. But BiPAP is the more effective intervention in the non-invasive ventilation part. And then for the intubated patient, you can modify minute ventilation. You can modify minute ventilation by increasing the respiratory rate or the tidal volume. So and that brings us to the main part of the talk, ventilation methods. So as I briefly mentioned, we'll have invasive ventilation that we'll just briefly look at via invasive airways like the endotracheal tube or tracheostomy. And we have our bigger group of the non-invasive ventilation methods. These are divided into non-invasive positive pressure ventilation and non-invasive negative pressure ventilation. An interesting part is that non-invasive negative pressure ventilation is a more physiologic way of doing that, right? So the iron lung, you have a patient who is subjected to negative inspiratory, negative thoracic pressure, expanding the rib cage and expanding the lung. So more physiologic, but definitely harder to perform. It requires, a lot of equipment, and the access to the patient is severely limited. So the typical way we provide non-invasive ventilation is by the positive pressure method. And the two main ways are CPAP, continuous positive airway pressure, or different methods of bilevel ventilation, bilevel positive airway pressure. And we'll talk a little bit about how they differ. Now there's a third way, using a high-flow nasal cannula, which technically is not a real positive pressure ventilation method, but we have found over time that high-flow nasal cannulas provide, with their high flows, provide a certain level of positive airway pressure that high-flow nasal cannulas can be considered under this group. Now, again, for non-invasive ventilation, ways we can modify supplemental oxygen. The simplest method by giving oxygen through a nasal cannula or a face mask supports oxygenation by increasing the inspired oxygen concentration. CPAP or high-flow nasal cannula supports oxygenation by increasing the inspired oxygen concentration, but also by improving the functional residual capacity, and by supporting breathing mechanics by stenting open conducting airways. And lastly, BiPAP has the same benefits as CPAP, with the addition that it supports ventilation by improving tidal volumes. Every time the patient takes a breath, a machine helps him with that and supports that. So to see here, on this axis you have a pressure measurement, on this axis you have time. So continuous positive airway pressure, a normal patient takes a breath in, breathes out, breath in, breathe out. And at some point we add CPAP at a certain level, well, let's say +5. So now you elevate all of those spontaneous breaths of the patient above the baseline of 0 here. Positive, continuous positive airway pressure. Bilevel positive airway pressure ventilation, same as CPAP. You provide that level of +5, and your breathing now occurs above the airway pressure of 0. But every inhalation here is supported by the ventilator, giving you an additional positive pressure. Okay, so here we come to the evidence based of how does continuous positive airway pressure help us with ventilation. So as I mentioned, if you have a positive pressure continuously applied to your respiratory system, it opens up airways, it opens up alveoli, and it actually helps you to overcome elastic forces. So the lung has a lot of elastic forces that tends to collapse the lung. Whereas this positive airway pressure stents those open. So you prevent atelectasis, you reduce VQ mismatch, you reduce pulmonary flow shunts, and you improve gas exchange. And with splinting open larger and smaller airways, this is especially helpful for children with tracheal bronchomalacia. So let's assume you take a child with tracheal bronchomalacia, you take an inspiration, you take a breath in. So what happens is, in children with tracheal bronchomalacia, airways collapse and create an increase in resistance and a decrease in gas flow. So you make the child work harder with those inspiration, and less gas reaches the alveoli. Now, if you splint those open with continuous positive airway pressure, you reduce inspiratory work, decrease respiratory muscle fatigue, and you prolong the gas exchange time and improve oxygenation. And lastly, we have found that CPAP reduces apnea in neonates, so apnea of prematurity, although the important part here is it doesn't affect central apnea, it affects obstructive and mixed apnea. BiPAP has exactly the same benefits as CPAP, again with that added benefit of augmentation of inspiration, so that increase your tidal volume and minute ventilation, and therefore it helps with ventilation, so with CO2 elimination, and it reduces inspiratory muscle work in addition. Unfortunately, everything in medicine, every good thing comes with certain negative aspects to it. And the main problems we see with CPAP and BiPAP, obviously too much positive pressure can lead to hyperinflation. If you start out with a lung that's already pretty inflated and you have a lot of pressure working against against you and you are hyperinflated, you actually increase respiratory muscle workload. And even more important, if you apply too much of positive pressure, you risk damage to your alveoli that, worst case, can result in a pneumothorax. Now, looking at the patient interface of how we deliver that positive pressure ventilation, a lot of problems that we have is positive pressure generates leaks. So let's say you have a nasal prong. The nasal prong will fit well in your nostrils, but it's not going to occlude them completely. So every time you apply positive pressure, there will be some loss of that positive pressure through the nose. And more importantly, the moment the patient opens his mouth, that's another way of actually losing positive pressure. Now, ventilator asynchrony with non-invasive positive pressure ventilation. I recommend to everybody, if you have access to a ventilator or an anesthesia ventilator, try it out, put them on pressure support, see how it feels, and then add a mandatory rate towards that. So if you're breathing and you suddenly take a breath out and the ventilator pushes a mandatory breath on you, it's really not comfortable. And it leads to a lot of patient discomfort and also an increase in respiratory muscle workload. Every time we have positive pressure ventilation and we increase the intrathoracic pressure, we have pressure on the vena cava, and we reduce venous return. And that's increasingly important in critically ill patients who have reduced hemodynamic parameters from the get-go. And then lastly, the patient interface. A lot of patient interfaces like nasal masks or face masks with straps, and they require a certain amount of pressure to actually achieve a good sealing condition to avoid leaks. So that can result in pressure points and skin damage. And other devices like nasal cannulas need to be applied with stickers or with certain aspects of glue, and all of this can damage fragile skin of neonates and younger children. And lastly, not so much a problem with nasal cannulas, but more a problem with the complete face mask. If you have a patient who has an episode of nausea and emesis, those can predispose to aspiration. So let's take a look of how we can address problems with oxygenation, hypoxemia. And let's take a look of all the different devices we have available here and what we can do. So starting first, we need to distinguish between low flow devices and high flow devices. A low flow device has a small bore tubing, like our nasal cannula or regular nasal cannula. And then high flow devices typically have larger tubing or the blue corrugated tubing, like the high flow nasal cannula, that actually supports the higher flows of oxygen. So nasal cannula, very simple. Provides oxygen flows between 0 and 6 liters per minute, but important to know that flows above 2 liters are uncomfortable because they dry out the nasal mucosa, they irritate, and they are not really effective of delivering actually a higher inspired oxygen concentration. Now, if you hook up this device to the wall oxygen, you actually get 100% of inspired oxygen, but with all the air leak around and air entrainment by breathing through the nose and the mouth, your delivered oxygen concentration is actually quite low, 24 to 44%, and about 4% increase for every liter flow. Come in different sizes to account for different sizes of our patient, obviously. The next step is the simple face mask. So that supports oxygen flows 5 to 8 liters per minute. The important thing here is to know that you should not use less than 5 liters per minute because as the patient breathes, there's carbon dioxide accumulation in that mask. So flows less than 5 liters don't clear that, and patients can re-breathe CO2. So the delivered FiO2 levels vary between 35 to 55%. And the same step up with each liter delivered in the inspired oxygen fraction. So a step up from those masks are partial and non-rebreather face masks. And the big difference is that they add a reservoir bag where oxygen can accumulate and be used by the patient with every breath. The partial rebreather has open ports here that allow expiration. The non-rebreather has ports that are sealed with a one-way valve and have another one-way valve down here for inspiration. So those one-way valves prevent rebreathing and allow the patient to use more of the pure oxygen that's stored in the reservoir bag. So here we have flows 6 to 15 liters. The important part for those masks is to ensure to keep a sufficient flow to keep that reservoir bag inflated. And the delivered inspiratory oxygen concentration varies between 50 to 70% with the partial rebreather and 70 to 100% with the non-rebreather. So lastly, what we have here available is the so-called oxy mask, and that mask is a special design that supports very low flows. As you can see, you can use the oxy mask with flows as low as 1 liter per minute, which would usually cause in certain oxygen masks rebreathing of carbon dioxide. This mask, due to this open design here, I'm just going to use this one here. This mask, due to the open design, is able to eliminate a lot of carbon dioxide. So the delivered FiO2 is variable, 24 to 90%, depending on the gas flow. And those masks are considered to be a little bit more comfortable for patients and allow and reduce the risk of rebreathing and aspiration because of their open design. So these are all ways of addressing oxygenation. All of those ways don't really help a lot with ventilation, so with carbon dioxide elimination. So and that's something that comes up in our next part. How do we address oxygenation and ventilation? So the one thing that I mentioned before is the high-flow nasal cannula. So the high-flow nasal cannula also uses nasal prongs and looks a little bit different than the regular nasal cannula, but is able to deliver very high flows of gas, so up to 60 liters per minute for the adult and 15 liters per minute for the infant. More importantly, it has the capability of being used together with a gas blender and with humidification. It supports oxygenation and ventilation by providing positive distending airway pressure at higher flows, so it provides a certain amount of CPAP. But the problem is that the actual CPAP value is hard to determine because of the fact that we have some leak from the nose, where the nasal cannula sits, and some leak from the mouth. So it's really hard to give you a certain number of CPAP that's being delivered by the mask. So here's a setup that features a blender where you can essentially, the upper part, sorry, that doesn't work anymore. The upper part shows the oxygen blender where you can dial in an inspired oxygen concentration. And the lower part features the flow meter where you can adjust the liter per minute flow that provides that distending pressure, that CPAP pressure. Now, how does the high-flow nasal cannula actually help us? So there are 3 effects that are at work here. Gas conditioning effects, flow effects, and pressure effects. Gas conditioning effects basically mean that instead of delivering a cold and dry oxygen mixture to the patient and having the patient work hard to humidify and heat that delivered gas, you can do this by the nasal cannula with a heater and a humidifier. So that reduces metabolic workload and takes pressure off the patient. Flow effects, it reduces inspiratory resistance. And more importantly, it washes out the nasopharyngeal dead space. So what does that mean? Higher flows completely saturate the nasopharyngeal area and the oropharynx with oxygen and basically eliminate carbon dioxide and eliminate any rebreathing, can really provide a higher amount of inspired oxygen. And lastly, the pressure effects, we can see here, this is the nostril, this is the nares inner diameter, and this is the prongs outer diameter. So if you have adequately sized prongs, you can really provide positive pressure by minimizing the leak and supporting the respiratory work. Now, a level above the high-flow nasal cannula is CPAP and BiPAP machines that provide those non-invasive ventilator support via different types of masks. And as you can see, there are a lot of different types available. So starting with nasal prongs, nasal cannulas, full face masks, nasal masks, total face masks, helmets, and mouthpieces. I think most of the time what we use are nasal prongs, nasal masks for our pediatric population. But obviously, part of this is limited by what the patient tolerates. Unique device is the RAM cannula. And the reason for that is it's versatile, that it looks like a regular nasal cannula, but it is able to support different ventilation modes. So it can be used as a normal nasal cannula, just providing oxygen. It can be used as a high-flow nasal cannula, but it also can be used to provide non-invasive positive pressure ventilation via a ventilator. It's important to mention that the evidence on the RAM cannula is a little bit out. So it's a device that probably needs a little bit more evidence base behind it, because there are some reports that it doesn't provide adequate ceiling pressures. And then lastly, not a device itself, but a support device for non-invasive ventilation is the neurally adjusted ventilatory assist. And what that means is if you have a ventilator that gives you pressure support ventilation, it waits for you to initiate a breath. And it does by flow or by pressure triggering. So it senses whenever you try to take a breath and it gives you a breath. This device is essentially a specialized nasogastric feeding tube that's placed into the stomach and has sensors that detect activity from the diaphragm. So the moment the diaphragm is activated by the patient to take a breath, that catheter recognizes the inspiratory effort and delivers pressure support to help with inspiration. And it doesn't only trigger the activity, it also measures the amount of activation of the diaphragm. So every time it delivers a support breath, it does so with proportional to the activity of the triggering for the diaphragm. So this is an example of non-invasive NAVA ventilation. So as you can see here down here, the EDI is that electrical activity generated by the diaphragm. So every time the diaphragm generates higher activity, if you look at the curve above the volume, the patient gets a larger breath. If it generates a lower activity, the patient generates a lower breath. And on the right-hand side, you have the EDI peak and min. These are the electrical activities, the minimal and the maximum activity. And these are numbers that the clinician can use to unload the diaphragmatic respiratory work. So you can adjust your NAVA level down here. That's essentially a level that's a multiplicator, that basically supports every breath that the patient takes. And you can adjust that to achieve unloading of the diaphragm. So lastly, invasive ventilation, just very briefly to mention endotracheal intubation and tracheostomies. Everything has advantages and disadvantages. Probably the main advantages for invasive ventilation is it really secures the airway. You typically have a cuff at the endotracheal tube or the tracheostomy that closes up the airway and prevents or reduces the risk for aspiration. You are in complete control. You can modify tidal volumes, respiratory rate, PEEP, oxygen, inspired oxygen pressures, and you can paralyze a patient and really reduce their metabolic workload. The problem is it has a lot of bad disadvantages coming with it. So you risk airway injury, you increase the risk for ventilator-associated pneumonia, you over time have respiratory muscle and skeletal muscle deconditioning in patients that are paralyzed and ventilated, and you risk in neonates and preemies subglottic stenosis from the cuff pressure. It also predisposes to the development of chronic lung disease and bronchopulmonary dysplasia in neonates. And that gets us to the last part of my talk today. Let's take a look at the evidence, and let's start with the neonatal population here. So respiratory care in the delivery room. There were 3 major trials: the COIN trial published in 2008, the SUPPORT trial in 2010, and the Vermont-Oxford Network Delivery Room Management trial in 2011. So without going into details, all of those essentially took premature infants and looked at a comparison between invasive mechanical ventilatory support with intubation or non-invasive ventilator support, predominantly with CPAP. There were some treatment arms, so all randomized controlled trials. There were some treatment arms that used surfactant, some prophylactically, some selective, but ultimately the main focus was to see how mechanical ventilation compares to non-invasive ventilation. And despite those many differences in trial design, the overall outcome of all 3 trials was a non-significant reduction in the rate of death or bronchopulmonary dysplasia at 36 weeks post-menstrual age in the non-invasive ventilation group versus intubation. Now, if you pooled the analysis, they actually found a small but significant reduction in risk of death or BPD in patients treated with CPAP. And that prompted the American Academy of Pediatrics to issue a policy statement saying that the early use of CPAP with subsequent selective surfactant administration in extremely preterm infants results in lower rates of BPD and death when compared with treatment with prophylactic or early surfactant therapy, and mainly also mechanical ventilation, because a lot of times surfactant administration required intubation and had a period of mechanical ventilation associated with that. Now, taking this a step further from CPAP in preemies and neonates, in 2016 and 2017, 3 Cochrane analyses have been published that look at respiratory support. The first one by Wilkinson looked at high-flow nasal cannula for respiratory support in preterm infants. And the author's conclusion was that high-flow nasal cannula has similar rates of efficacy than other forms of non-invasive respiratory support in preterm infants in preventing treatment failure, so intubation, death, and chronic lung disease. Looking at Cochrane reviews that actually compare nasal intermittent positive pressure ventilation to nasal continuous positive pressure ventilation, so CPAP, what we had initially in the delivery room, showed that early treatment with nasal intermittent positive pressure ventilation significantly reduced the risk of meeting respiratory failure criteria and the need for intubation in infants. There was no risk reduction in chronic lung disease, though. And so the author concluded that early nasal intermittent positive pressure ventilation appeared to be superior to just nasal CPAP for decreasing those outcomes. And the third Cochrane review very similarly looked at nasal intermittent positive pressure ventilation versus nasal CPAP in preterm neonates as a support after extubation, and also found a significantly reduced risk of extubation failure and needing reintubation if you use early non-invasive positive pressure ventilation versus CPAP. Now, all of this evidence was centering more on preemies and delivery room care, but non-invasive ventilation at the same point also has benefits, a lot of benefits in pediatric patients in general. So just to give you a couple of ideas in different disease groups, it was looked at in asthma, and it was found to have more rapid decline in symptom scores and decrease in hospital admission and length of stay. In bronchiolitis, non-invasive ventilation was found to help avoid intubation and should be trialed early on. Pediatric ARDS is a little debated, and the authors of different studies were overall in agreement that severe ARDS requires invasive ventilation and invasive support. But mild ARDS and early ARDS, especially in immunocompromised patient, a lot of authors argue that deserve a trial of non-invasive ventilation to see if intubation can be prevented or at least not used very early on. Cystic fibrosis, non-invasive ventilation can improve FEV1 or reduce the rate of its decline. In obstructive sleep apnea, CPAP is considered a treatment modality, although not so much in pediatric populations, because for pediatrics we have different pathomechanisms behind obstructive sleep apnea, and we can often address it in different ways, although in the adult population, CPAP is one of the treatment modalities. And then lastly, neuromuscular disease, non-invasive ventilation can help avoid intubation in respiratory failure, and it has been found in cardiac disease after surgery and after extubation can prevent extubation failure and has produced shorter ICU and hospital length of stays. At the same route, the benefits of NAVA. Again, NAVA as an assist device for non-invasive ventilation. So a couple of different studies, all randomized controlled trials or crossover studies. But overall, the big summary of those studies is that NAVA versus conventional ventilation or pressure control ventilation leads to overall lower sedation utilization. It reduces peak inspiratory pressures, and it allows the clinician to actually reduce the required inspired oxygen concentration. And in overall, it produces a better tolerance by the patient by improving patient ventilator synchrony. Okay, so lastly, how do we monitor the adequacy of oxygenation and ventilation? So for oxygenation, we have pulse oximetry, which gives us a very good point of care understanding of our oxygenation. There are ways of monitoring O2 concentrations transcutaneously, but they are very cumbersome because they require a lot of equipment set up. And then gold standard remains the arterial blood gas analysis. Ventilation the same way. Transcutaneous is difficult to achieve. Blood gas analysis is the gold standard. And capnography, so end-tidal CO2, is fraught with some disadvantages. If you do not have an airway that avoids any leaks, you typically don't get a very accurate reading. It's more useful in making sure that the patient is actively breathing rather than getting a clear number and a clear understanding of what the arterial partial pressure of your carbon dioxide concentration is. So that brings us to the gold standard, our blood gas analysis, the gold standard for assessment of oxygenation and ventilation. We have different sampling sites, arterial blood gases from umbilical artery catheters, arterial lines, arterial puncture sites. And then there's the way of obtaining capillary blood that's arterialized by heating up the extremity. And then obviously venous, central venous, pulmonary venous, and peripheral venous. For the blood gas analysis, we have components that are directly measured, pH, PO2, PCO2, and lactate, and a couple of components that are derived and not directly measured, like the bicarbonate concentration or base excess. As you can imagine, again, gold standard is an arterial blood gas analysis, but it's not that easy to continuously have access to an arterial blood gas. Placement of arterial lines has its own large amount of problems. And placement of and repeated punctures can also result in problems. And that prompted investigators to look at the possibility of using surrogate markers like capillary blood samples or venous blood samples and correlate those with different measurements. And all of those studies looked at different patient populations, so PICU patients or neonates, and compared arterial, venous, and capillary blood samples. And the overall consensus was that between arterial blood gases and capillary blood gases, there was a good correlation between pH, PCO2, but not so much between PO2. So if you want to get a good understanding of your oxygenation, the arterial blood gas remains your standard of care. Whereas capillary blood gas samples usually produce good agreement on pH and PCO2. And specifically, this studies said that capillary pH usually is lower than arterial blood gas pH, but 95% of values were falling between plus minus 0.032, and the difference was never greater than 0.05, so which is a pretty good for pH. And the capillary PCO2 is usually higher than the arterial blood gas PCO2, but again, 95% of values were falling between plus minus 4.5 millimeter quicksilver, and most patients were within the 6.5 millimeter range. So again, a good agreement overall, and a good surrogate to if you don't have access to an arterial blood gas. So that essentially almost concludes my talk. The only last part that I wanted to mention is oxygen is a therapeutic modality that we use very often, on the wards, in the operating room, in the ICU. But unfortunately, it has detrimental effects and it has problems with its use. In the past, a lot of times we considered more is better. So in an anesthetic emergency, the first thing we do is we increase our FiO2 to 100%. If you have a patient who has a cardiopulmonary arrest, the first impulse is to get 100% oxygen, ventilate. If you deliver a newborn who has bad oxygenation, the first impulse seems to be to use a lot of inspired oxygen. But again, all of those has now shown to be associated with problems, so we're becoming more judicious with the use of supplemental oxygen. And just to kind of bring up a couple of things, retinopathy of prematurity, bronchopulmonary dysplasia, and periventricular leukomalacia are problems with prolonged and high oxygen use. We talked briefly about oxygen therapy in the delivery room. And then even oxygen therapy for us during anesthesia is not the best way to address things because a lot of pulmonary absorption atelectasis impairs postoperative recovery of patients. And then lastly, in patients with cardiac lesions, oxygen can be used to modify pulmonary vascular resistance. But for example, in a patient with a large VSD or an atrioventricular canal, septal canal defect, who has a significant left to right shunt, if we increase his oxygen concentration and reduce pulmonary vascular resistance, you actually help that left to right shunt and you risk pulmonary overcirculation. So judicious use of oxygen is kind of the main part. Okay, and that concludes my talk. Thank you very much. Any questions?
Thank you, Ben.
So I have a question. You mentioned kids with neuromuscular disorders, and I take care of children with Prader-Willi syndrome who have significant respiratory hypotonia. Do you use CPAP or BiPAP, or recommend CPAP or BiPAP in kids like that, in post-op or in respiratory illness, or what would be beneficial?
Thank you. So, excellent question. So, Prader-Willi syndrome, a lot of it depends on the main etiology of what we're looking at with the respiratory failure. So, again, a lot of it is obstructive in nature. So, CPAP and BiPAP can definitely help with that. When we do anesthesia, or we put those patients under anesthesia and have them in the recovery room, what we often see is, we have more difficulties with respiratory drive from a central perspective, but also more difficulties with obstruction. So we start with doing some positional maneuvers, but a lot of times in patients with predisposing conditions, we actually go very quickly to respiratory support. And an easy way for us to do it without a lot of setup is really the high-flow nasal cannula, and that's the first step that we take. But very often the high-flow nasal cannula, the high-flow nasal cannula in the majority of patients is enough. But if they have very significant obstruction or have a component that requires some non-invasive positive pressure ventilation beyond that, so central apnea periods that you need to support them through, then we would move upwards to more like a CPAP, BiPAP device. Yeah, but we definitely utilize it post-operatively, and I think there's good evidence out there to utilize it even in home settings, and more of those machines are transitioned to chronic respiratory support at home.
Thank you for the very complete overview of non-invasive ventilation. My question is about the use of non-invasive ventilation, and particularly high flow for asthma. I completely get why physiologically this is good for bronchiolitis and neuromuscular diseases, but why does it physiologically help asthma where the problem is not air going in, it's air going out?
That's a very good question. So I struggled a little bit with putting the asthma part on that slide. And the reason is that there are a couple of studies that investigate this. And some of those studies were presented in one of the respiratory care forums, and that was exactly the same point of criticism that was brought up. And the idea behind that is that in a very, very monitored patient setting where you have respiratory care essentially at bedside, adjusting and monitoring the patient, there is apparently some benefit to, and I agree with you, with asthma, the main issue is really the exhalation, right? But apparently the provision of some distending pressure actually helps with still opening and recruitment. In addition to some of those studies looked at providing not only that non-invasive respiratory support, but adding nebulization and adding all of the other therapies that we use to address asthma. Now, in that forum, it was mentioned that this is not ready for prime time. Nobody really would put that into an emergency department or put that. But people are investigating the potential use of it in very select patient populations going forward. But I agree with you. It's not. It's a little bit like the ARDS question, right? You would, in severe ARDS, you would never think about using non-invasive ventilation because you know it's going to fail. And in the standard asthma population, you definitely have better treatment modalities to start. What I was trying to show with that is that there is some research going into that direction. Some authors claim to have found some benefits, but it's highly debated right now, and it's interesting to see where it's going to go further down.
It's very interesting that I completely agree it's highly debated, but it has become standard care. You cannot admit somebody here with standard practice, exactly, without them being on high flow. And I don't think the research supports it yet, but if I try to admit somebody without high flow, they're like, what's wrong with you?
Thank you. That's a more complicated question, Mark.
So you commented early on about the benefits of negative pressure ventilation. So I'm curious about what's the status of things like diaphragmatic pacing or phrenic nerve stimulation? Is there a role for those in pediatric patients?
That's a very good question. I know that there is, I think, more evidence out there right now in the adult literature. And I have to admit, I have not explored that area more. So what we know is for the pediatric population where we actually have used negative pressure ventilation is for pediatric patients with very significant ribcage abnormalities, for example, where you really have problems of supporting a regular respiratory drive. So in that particular part, it has been used. But I have to say, I'm not aware of the current state of like those negative. Sorry.
Other questions? All right, thank you very much.
Okay, thank you very much.
Thank you.
You have been disconnected from the meeting.